Hello and welcome everybody to the first ever aHUS patient webinar being organized by the Atypical HUS India Foundation in partnership with NephroPlus, Dialysis Centers and the Kidney Warriors Foundation. We're really excited to be organizing this webinar. There is one important reason we are doing this webinar today. Most patients and their families on the call are probably aware that the situation for aHUS patients until about a year or two back was very frustrating. We all knew there were treatments available in some countries in the world, but we did not have access to those drugs. As an aHUS advocate put it so well, an accident of genetics combined with an accident of geography had condemned us. However, recently there has finally been some hope. We at the Atypical HUS India Foundation could not be more hopeful than at any time in the past that the future is going to be better for aHUS patients in India. I invite all patients and families who've joined this webinar to please register with our foundation so we can keep you all informed of all the developments in this disease. Sign up for our newsletter as well. It is a once in a few months newsletter, no spamming, I promise. And also please record a short video of your journey so we can let others know that they are not alone in this disease, in this journey, and they can get inspired and be hopeful of a better future. So without further ado, I'd like to dive into the program today. We have a really exciting program lined up for you. We have some stellar speakers with decades of experience behind them and who are really passionate about atypical HUS, something that is really difficult to find today. So our first speaker today is Dr. Arvind Bagga, who's a globally recognized pediatric nephrologist with almost 4 decades of experience. He serves as the director at Indraprastha Apollo Hospitals, New Delhi, and is professor emeritus at AIIMS in New Delhi. His contributions span clinical care, research, and authorship in pediatric kidney diseases, and he has a huge body of work in atypical HUS. Thank you so much, Dr. Bagga, for taking the time to speak to all of us today. I hand over the platform to you.
Thank you, Kamal, and thank you to the aHUS Foundation for this opportunity to speak to all of you. I'll just try sharing my slides. Just one second. It's a tough thing for me. Kamal, is it possible that I send them to you? I think it's
Yeah. Sure, Dr. Bagga.
I'll just try once more. Yeah.
So you could send them to me also. I can do that.
Okay. Yeah.
We can see your slides now.
You can see the slides. Very good.
Yes.
Good. Yeah. So thank you, Kamal, and thank you everybody for this opportunity to be here and to speak to all of you on atypical HUS. At the outset, I think I'd like to thank the foundation and our institutions, the All India Institute of Medical Sciences, KEM, and many other such institutions in the country who have helped us advance this specialty across the country. I must refer to 2 booklets, one in Hindi, the other in English, that were made by the All India Institute. And these are freely accessible, and you can write to me or to Kamal for access to these booklets. These are for parents, and we hope that you can use them. So while going ahead, I think many of you would understand that one of the important mechanisms when you are affected with various infections is immunity. Immunity is something that helps you fight infections. Now, immunity is chiefly of 2 types. One is the innate immunity, the one shown in pink, and the other is the adaptive immunity, or things that you learn, the body learns when exposed to a previous infection. The innate immunity kicks in immediately. As soon as you are exposed to an organism, say an organism or anything that's toxic, the innate immunity starts acting within seconds to minutes, and definitely by hours, it's able to take care of the organism, kill the organism, and so on. The adaptive immunity, which relies mainly on B cells, T cells, जिसके बारे में आप लोगों ने कई बार सुना होगा, adaptive immunity बाद में अंदर आती है. सो कुछ घंटों के बाद या कुछ दिनों के बाद एडेप्टिव इम्यूनिटी शुरू होती है, बट इमीडिएटली जो बॉडी का डिफेंस है वो इनेट इम्यूनिटी से होता है। और जो कॉम्प्लीमेंट है उसमें बड़ा इंपॉर्टेंट एक तत्व है या बहुत इंपॉर्टेंट केमिकल है जो हमें इनेट इम्यूनिटी का एक पार्ट है, जो हमारी बॉडी को प्रोटेक्ट करता है। जो कॉम्प्लीमेंट पाथवे है, essentially, don't get too much confused with this complex slide, but essentially it involves three pathways: the alternative pathway, the classic pathway, and a lectin pathway. The alternative pathway is the fastest to act. So as soon as you're exposed to an infection, a number of steps start kicking in one after the other. As you can see here, C3 से C3b बन जाता है, C3b को फिर आगे एंजाइम्स तोड़ के C5 बना देती हैं, और जो C5 है वो जाके बैक्टीरिया में जाके उसको जाके डैमेज कर देता है या उसको मार देता है। तो एक कॉम्प्लीमेंट सिस्टम हमारी बॉडी में एक सिस्टम है ताकि हम इमीडिएटली किसी भी बीमारी के अगेंस्ट हम लड़ पाए। ऑब्वियसली कॉम्प्लीमेंट सिस्टम हमेशा एक्टिव होता है। इमेजिन करो अगर एक चीज हमेशा एक्टिव रहेगी तो वो वाइल्ड बैक्टीरिया को मारेगी पर कुछ नॉर्मल सेल्स को भी मार देगी। तो इसलिए कॉम्प्लीमेंट सिस्टम को ब्रेक लगा के रखने के लिए बॉडी ने कुछ फैक्टर्स बनाए हुए हैं, जैसे फैक्टर H, फैक्टर I, CD46, and these factors are really the brakes that keep the complement system in check. Now imagine if these brakes were to fail. And if they were to fail, the complement system would become overactive. And again, there would be damage, not only of the bacteria, but also of the normal cells. तो एक तो ये ब्रेक अगर फेल हो जाए तो मुश्किल है। कभी कभी क्या होता है कि ब्रेक फेल नहीं होती, ब्रेक्स तो होती हैं, पर बॉडी के अंदर एंटीबॉडी आ जाती है जो इन ब्रेक के अगेंस्ट काम करती है। टिपिकल एग्जांपल है फैक्टर H ऑटो एंटीबॉडीज का, जो एक इंपॉर्टेंट कारण है किस कारण HUS होता है। और जब बॉडी में ये फैक्टर H ऑटो एंटीबॉडी होती हैं तो फैक्टर H को काम नहीं करने देती। एक तरह से इससे भी ब्रेक फेल हो जाती है और कॉम्प्लीमेंट सिस्टम फिर ओवर एक्टिव हो जाता है। सो ओवर एक्टिविटी ऑफ द कॉम्प्लीमेंट सिस्टम ही मूल्य कारण है जिस कारण एटिपिकल HUS होता है। अब HUS चीज क्या है, HUS क्या बीमारी है? मोटे तौर पे अगर देखा जाए तो HUS के दो मेजर कारण हैं। एक है जो इन्फेक्शन से होता है, जिसे हम कहते हैं शुगर टॉक्सिन, जो एक मेन टॉक्सिन है जो कुछ बैक्टीरिया बनाते हैं जिस कारण दस्त लग सकते हैं, दस्तों में खून आ सकता है एंड सो ऑन। और दूसरा होता है कॉम्प्लीमेंट एसोसिएटेड, अभी जो इसके बारे में हम बात कर रहे थे। दुनिया भर में शुगर टॉक्सिन एसोसिएटेड HUS काफी कॉमन है। मेनली इसलिए कॉमन है क्योंकि जिस तरह का वो मीट खाते हैं, स्पेशली जो बीफ खा रहे होते हैं, उससे एक्सपोजर ज्यादा होता है इन चीजों का। आपको मैं बताना चाहूंगा कि जो पहला एपिडेमिक हुआ था HUS का ऑलमोस्ट 50 साल पहले, वो बर्गर, एक जैक इन द बॉक्स एक फूड चेन थी, उस पर शुरू हुआ और वो लोगों ने बर्गर खाए जिन बर्गर्स की पैटीज में शुगर टॉक्सिन वाले बैक्टीरिया थे। सो हमारे देश में ये चीजें अभी बहुत ज्यादा प्रचलित नहीं है। नंबर वन, हम लोग बहुत ज्यादा बीफ नहीं खाते हैं, तो क्लियरली इस समय शुगर टॉक्सिन एसोसिएटेड HUS यानी इस प्रकार का HUS रिलेटिवली अनकॉमन है। और हमारे देश के अंदर ज्यादातर जो हम HUS देख रहे होते हैं, बच्चों में भी और एडल्ट्स में भी, वो कॉम्प्लीमेंट एसोसिएटेड HUS है, या जिसे हम एटिपिकल HUS बोलते हैं। जिसे आपको मैंने बताया, ये कॉम्प्लीमेंट एसोसिएटेड HUS के दो कारण होंगे। या तो वो ब्रेक्स जो हैं जो होनी चाहिए, वो ब्रेक अगर फेल हो जाए, कि हमारे शरीर के अंदर कुछ जेनेटिक डिफेक्ट है, कुछ चीजें पैदाइशी हैं जो हमने इनहेरिट की हैं, या अपने आप भी हो जाती हैं कई बार, अगर ये जेनेटिक म्यूटेशंस है या एंटीबॉडी है, तो इससे क्या होगा, कॉम्प्लीमेंट सिस्टम ओवर एक्टिव हो जाएगा। बिकॉज कॉम्प्लीमेंट सिस्टम ओवर एक्टिव हो जाएगा तो वो बाकी चीजों को तो मारेगा ही मारेगा, पर जो नॉर्मल सेल्स भी हैं उनको भी मारना शुरू कर देगा। तो हमारी जो नसें हैं, जो ब्लड वेसल्स हैं, उनमें उनमें भी आघात आता है। तो HUS के अंदर प्राइमरीली जो डैमेज हो रहा होता है, हमारी जो ब्लड वेसल्स में एंडोथेलियल सेल्स हैं, जो एक तरह से लाइनिंग है ब्लड वेसल्स की, उस पर आघात आता है। और उन एंडोथेलियल सेल्स के डैमेज के कारण वहां पे छोटे छोटे क्लॉट बन जाते हैं, जहाँ पे जिस कारण तो ब्लड वेसल्स में मल्टीपल क्लॉट्स होते हैं। जब हमारे खून के जो रक्त के जो आरबीसीज है, जब वो क्लॉट के थ्रू निकलते हैं तो टूट जाते हैं, और इसी कारणवश अनीमिया होता है। तो अनीमिया जो होता है, हेमोलिटिक अनीमिया, वो इसलिए हो रहा होता है बिकॉज ये आरबीसीज हमारे टूट रहे होते हैं। इसके अतिरिक्त जब प्लेटलेट्स भी जो है वो भी इस क्लॉट्स में जब या तो वो इन्वॉल्व हो रही होती है क्लॉटिंग प्रोसेस में, या क्लॉट में डैमेज भी हो रही होती है, उस कारण प्लेटलेट्स भी कम हो जाती है। सो अनीमिया होना, खून की कमी होना, प्लेटलेट्स कम हो जाना, और क्योंकि ये बहुत सारी ये वेसल्स जो हैं, जो छोटी छोटी जो ब्लड वेसल्स हैं, हमारी किडनी के थ्रू जारी होती हैं, क्योंकि किडनी में भी इफेक्ट होता है, तो इसलिए किडनी फेलियर भी, किडनी इंजरी हो जाती है। तो ये जो ट्रायड है, अनीमिया का, प्लेटलेट्स कम हो जाने का और किडनी फेलियर का, वो सब मिला के एचयूएस बनाते हैं ना। इसके मेन सिम्टम क्या है बीमारी के, और आप में से बहुत सारे पेरेंट्स को और बच्चों को ये बात पता होगी। मेन फीचर होते हैं वो ये होते हैं कि पेशाब की मात्रा कम हो जाएगी, पेशाब का रंग थोड़ा लाल आ सकता है, पीलापन आ सकता है बिकॉज रेड सेल्स डिस्ट्रॉय हो रहे हैं, बहुत रेयरली हल्का सा जॉन्डिस भी हो सकता है, आंखों में पीलापन आ जाना। बहुत सारे बच्चों में और एडल्ट्स में भी जब बीमारी शुरू हो रही होती है, बिकॉज ये सब कुछ हो रहा होता है, तो बच्चे और एडल्ट्स पेट में दर्द की कंप्लेन करते हैं, कभी कभी उल्टियां वगैरह भी होती हैं, और बहुत सारे लोगों को खून चढ़ाने की आवश्यकता पड़ सकती है। यही सिम्टम मेन बीमारी में होते हैं, और यही सिम्टम जब रिलैप्स हो तब भी होते हैं। तो अगर बीमारी दोबारा भी कभी होती है कुछ महीनों बाद, तब भी ऐसे सिम्टम ही आएंगे। सो पेशाब की मात्रा कम हो जाना, लाल रंग का पेशाब आना, पेट में दर्द, उल्टियां, खून की कमी होना, और ये सारे सिम्टम होंगे जो मेन सिम्टम के बारे में आपको पता होना चाहिए, और टाइम पे डॉक्टर से संपर्क करना चाहिए। अगेन थोड़ी स्लाइड कॉम्प्लेक्स है, पर ये एसेंशियली ये बताती है कि जब आप एक हॉस्पिटल जाते हो, सारे सिम्टम लेके, अनीमिया लेके कि आपको खून की कमी है, प्लेटलेट्स कम है, और आपकी किडनीज काम नहीं कर रही, तो आपके जो डॉक्टर हैं, दे आर डूइंग अ नंबर ऑफ टेस्ट्स टू फिगर आउट कि बाकी बीमारियां तो नहीं है। सो दे विल लुक फॉर इन्फेक्शंस, they will, in adults they would also look for this condition which Dr. Lobo will explain to you later. कुछ केसेस में एचयूएस जो है वो एक और किसी बीमारी के कारण हो सकता है। फॉर्चुनेटली ये चीजें कम है, और जैसे मैंने कहा कि हमारे देश में शेगर टॉक्सिन एसोसिएटेड एचयूएस भी काफी कम है, ऑल्दो दुनिया भर में ये काफी इंपॉर्टेंट है, बिकॉज इस तरह के हम वो खाना वाना खाते हैं और इस तरह के इन्फेक्शन के रिस्क ज्यादा होता है। तो एक बार ये सारी बीमारियां एक्सक्लूड हो जाएं एक एचयूएस के मरीज में, तब सोचते हैं कि नहीं, अच्छा ये बीमारियां नहीं है, तो ये एटिपिकल एचयूएस हो सकता है। और बिकॉज मेजॉरिटी ऑफ एटिपिकल एचयूएस कॉम्प्लीमेंट सिस्टम के ज्यादा एक्टिव होने के कारण होता है, इसे कॉम्प्लीमेंट मीडिएटेड एचयूएस भी बोलते हैं। जैसे मैं आपको आगे बताऊंगा, हमारे एटलीस्ट बच्चों के अंदर ऑलमोस्ट आधे बच्चों में जिनको एटिपिकल एचयूएस होता है, उनमें फैक्टर एच एंटीबॉडी होती है, तो इसकी भी जांच की जाती है। जब आप हॉस्पिटल जाएंगे तो ये जांच की जाएगी, और अगर एंटीबॉडी आएगा तो उसका अलग उपचार किया जाएगा। अगर एंटीबॉडी नहीं है तो फिर जेनेटिक कारण हो सकता है, जैसे मैंने बताया कि वो ब्रेक्स जो थी वो नहीं है, और फिर हम उसके लिए जेनेटिक टेस्ट करते हैं, जिसके लिए स्पेशल टेस्ट किए जाते हैं। ये कुछ जांचें हैं जो आपके डॉक्टर करेंगे हॉस्पिटल में। आप लोगों ने बहुत सारी जांचों में खून के कुछ टेस्ट होंगे, पेशाब के टेस्ट होंगे, अगर आपको डिसेंट्री है कि स्टूल में ब्लड आ रहा था तो शेगर टॉक्सिन देखने के लिए स्टूल एग्जामिनेशन भी किया जा सकता है। फैक्टर एच ऑटो एंटीबॉडीज एक इंपॉर्टेंट जांच है जो हम बच्चों में करते हैं, और C3 जो टेस्ट करते हैं वो कॉम्प्लीमेंट की एक्टिविटी देखने के लिए एक जांच होती है। सो जैसे मैंने बताया कि बच्चों के अंदर ऑलमोस्ट आधे बच्चों में एंटीबॉडी होती है, और लगभग 30% में कुछ कारण मिल नहीं पाता। बाकी 20% में कोई ना कोई जीन्स होती हैं जो इंपॉर्टेंट होती हैं, और जो इंपॉर्टेंट जीन्स हैं वो यहाँ लिस्टेड है। फैक्टर एच, फैक्टर आई, C3, बहुत छोटे बच्चों में DGKE भी एक इंपॉर्टेंट जीन है जो जिस कारण परेशानी हो सकती है। फिर मैंने जैसे आपको बताया कि लगभग 30% में कुछ कारण मिल नहीं पाता है, और हमें लगता है कि परहैप्स जैसे जैसे रिसर्च होगी और नई जीन्स हमें मालूम पड़ जाएगी। इंपॉर्टेंट बात ये सोचनी याद रखनी है कि जो एंटीबॉडीज हैं वो ज्यादातर स्कूल गोइंग बच्चों में ज्यादा होती है। सो 5 साल के करीब से लेके 15 साल तक ये बीमारी होती है। सिमिलरली जो CD46 वाली बीमारी भी है वो भी इसी एज ग्रुप में है। बाकी बीमारियां किसी भी एज पे हो सकती हैं, एक्सेप्ट कि जो DGKE है जो बड़ी रेयर बीमारी है पर हमारे देश में पाई जाती है, वो बहुत छोटे बच्चों में होती है। तो जब भी हम HUS सोचेंगे और अगर एंटीबॉडीज नहीं है तो जेनेटिक टेस्ट किए जाएंगे और करने के कारण लिखे हुए हैं कि अगर एंटीबॉडी नहीं मिलती, बहुत जल्दी बीमारी शुरू हो जाती है, या हमने प्लाज्मा एक्सचेंज किया उससे फायदा नहीं हुआ, किसी में परिवार में हिस्ट्री है ऐसी बीमारी की, क्या ट्रांसप्लांट से पहले भी कभी 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 हम जेनेटिक्स के टेस्ट करते हैं। तो जेनेटिक टेस्ट करना काफी इंपॉर्टेंट टेस्ट है एटिपिकल HUS की इवेल्युएशन में। उसका कारण पता करने के लिए जेनेटिक स्टडीज करना काफी इंपॉर्टेंट माना जाता है। इस पे अगेन ज्यादा आई थिंक परेशान होने की बात नहीं है स्लाइड के ऊपर, पर मोटे तौर पे मैं जो बता रहा हूँ कि जेनेटिक डिफेक्ट्स दो तरह के होते हैं। एक होते हैं ऑटोसोमल डोमिनेंट, जहां पे अगर एक पेरेंट को बीमारी है तो उसके जो आधे बच्चे होंगे 4 में से 2 बच्चों को बीमारी दे सकता है। ऑटोसोमल रिसेसिव अलग तरह की चीज होती है, जिसमें अगर पेरेंट्स तो नॉर्मल हैं पर उनमें उनके 4 में से 1 बच्चे को बीमारी हो सकती है। तो अगर रिसेसिव डिसऑर्डर है तो 25% चांस है कि अगले बच्चे में हो सकता है। डोमिनेंट डिसऑर्डर है तो 50% चांस है कि अगले बच्चे में हो सकता है। तो हमेशा जरूरी है कि अगर आपके परिवार में एक बच्चे को एटिपिकल HUS है और इसमें जेनेटिक डिफेक्ट पाया गया, तो अगली प्रेगनेंसी के दौरान अपने डॉक्टर से जरूर संपर्क करिए ताकि वो जांच करके बता पाए कि वो बच्चा सेफ है या नहीं। सो अगर जैसे मैंने ऊपर दोबारा बता रहा हूँ कि अगर जेनेटिक टेस्ट पॉजिटिव आया इन जीन्स के लिए, पर्टिकुलरली ये अच्छे जीन्स जो इंपॉर्टेंट जीन्स हैं, फैक्टर H, CD46, फैक्टर I, C3, फैक्टर B और DGK, या कुछ और अन्य जीन्स भी होती हैं जो विशेष प्रकार की जीन्स होती हैं, अगर इनमें कोई डिफेक्ट आता है तो आपके जो बाकी बच्चे हैं उनमें भी जांच करनी चाहिए। इतना महंगा चार्ज नहीं होता ये, तो सेंगर सीक्वेंसिंग करते हैं जो 5-6 हज़ार रुपये में हो जाती है। और अगर सेंगर सीक्वेंसिंग पॉजिटिव आती है तो बाकी बच्चों की भी जांचें होनी चाहिए खून की, देखने के लिए कि उनको तकलीफ है या नहीं है। यहाँ पे आपको मैं एक तरह से अच्छी बात ये बताना चाहूंगा कि कभी 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 क्या होता है कि एक परिवार में एक से ज्यादा बच्चे को जेनेटिक डिफेक्ट होता है पर बीमारी सबको नहीं होती। तो ये पक्की बात नहीं है कि डिफेक्ट होना बीमारी के साथ 100% बीमारी होगी। चौकन्ना रहना जरूरी है, पर बीमारी जो है वेरिएबली होती है, पेनिट्रेंट। तो कुछ बच्चे ऐसे भी हो सकते हैं आपके जिनको सेम डिफेक्ट हो पर बच्चे बिल्कुल ठीक रहे। पर एज पेरेंट्स आपको यू शुड बी अवेयर, और अगर वो कभी बीमार पड़ते हैं तो उनकी जांच तुरंत होनी चाहिए। HUS को हम लोग मैनेज कैसे करते हैं, जैसे शुरू में कमल ने कहा कि अभी तक हमारा जो डायग्नोसिस था वो ऑब्वियसली हम प्लाज्मा इन्फ्यूजन पे या प्लाज्मा एक्सचेंज पे ही बेस्ड, और हम यही हमारा मेन इलाज का एक जरिया था जिससे हम मैनेज करते थे। अगर एंटीबॉडी आ जाती थी जो अबाउट 55% पेशेंट्स में आ जाती है तो वहां पे हम प्लाज्मा एक्सचेंज कंटिन्यू करते हैं। इसके अलावा हम कुछ स्टेरॉइड्स के अलावा एक आधी दवा और देते हैं ताकि वो एंटीबॉडी ना बने और बच्चा तंदुरुस्त रहे। अगर एंटीबॉडी नहीं आती है तो अभी तक हमारे पास इलाज कुछ नहीं था सिवाय इसके कि हम प्लाज्मा एक्सचेंज ही करें और जेनेटिक्स की वेट करें। और अगर जेनेटिक्स में कोई रिजल्ट पॉजिटिव आता है तो फिर हम ये स्पेसिफिक एक स्पेशल दवा है एक्लूजिमैब, जो फैक्टर 5 ब्लॉकर है, जो कॉम्प्लीमेंट सिस्टम को आगे जाके रोक देती है। अभी तक इस दवा की हमारे पास अवेलेबिलिटी नहीं थी, पर इस लगता यह है कि अगले कुछ महीनों में ये दवा अवेलेबल हो जाएगी। तो एक्लूजिमैब हम लोग यूज कर सकते हैं बच्चों में जिनको जेनेटिक्स के डिफेक्ट है। ये या दुनिया भर में जैसे होता है कि वहां पे जैसे HUS डायग्नोसिस किया जाता है वहां पे एक्लूजिमैब तुरंत यूज शुरू कर दी जाती है और चलती रहती है कुछ समय के लिए जब तक रिपोर्ट पक्की एक फाइनल रिपोर्ट ना आ जाए। और आखिर में 1 या 2 स्लाइडों में मैं बताना चाहूंगा कि हमें प्रिकॉशन क्या रखने हैं जब बच्चे का इलाज चल रहा है, चाहे तो प्लाज्मा एक्सचेंज से या एक्लूजिमैब पे। एक्लूजिमैब एक बहुत अच्छी दवा है, बट एक्लूजिमैब क्योंकि कॉम्प्लीमेंट सिस्टम को गड़बड़ करती है, उसको वो एक तरह से ब्रेक लगा देती है। सो अब बॉडी के जो इम्यूनिटी है वो क्लियरली नीचे चली जाती है। तो क्लियरली हमें केयरफुल होना चाहिए कि अगर बच्चे को बुखार आ रहा है, सिर में दर्द है, उल्टियां हो रही हैं, तो तुरंत डॉक्टर को संपर्क करें। इसके अलावा कुछ वैक्सीन हैं जो देने आवश्यक हैं। मेनिंगोकोकस, निमोकोकस, ये वैक्सीन देने जरूरी हैं अगर हम इक्लूजिमैब थेरेपी देते हैं, बिकॉज बॉडी ऑर्गेनिजम्स को के अगेंस्ट लड़ नहीं पाती। इसके अतिरिक्त एंटीबायोटिक्स भी देनी पड़ेंगी लॉन्ग टर्म, जब तक इक्लूजिमैब ट्रीटमेंट चलती नहीं रहेगी, और चाहे 6 महीने चल रही है, चाहे साल भर चल रही है, या आगे भी चल रही है। बच्चा अगर प्लाज्मा एक्सचेंज पे है तो उसके अपने साइड इफेक्ट्स हैं, इसके बारे में अगर आप सवाल होंगे तो उनको आंसर करेंगे। In addition, be aware that HUS is a serious illness. HUS अपने आप में एक बीमारी है जो आगे काफी हाई प्रोपोर्शन में जिनमें क्रॉनिक किडनी डिजीज हो जाती है। बीमारी किडनी की आगे बढ़ सकती है, तो बच्चे का ब्लड प्रेशर हमेशा चेक करते रहना, दवाओं के साइड इफेक्ट्स को मॉनिटर करना, और हमेशा ध्यान रखना कि सब कुछ करते हुए भी, प्लाज्मा एक्सचेंज करते हुए भी, दवाई देते हुए भी, रिलैप्स का एक रिस्क है। और एज पेरेंट्स आपका रोल ये रहेगा कि रिलैप्सेस को जल्दी पकड़े। सो ब्लड प्रेशर का इलाज, यूरिन में प्रोटीन चेक करते रहना, और रिलैप्स के लिए हमेशा मतलब दिमाग में रखना कि ये परेशानी आ सकती है। फॉलो अप पे हम चाहेंगे कि आप बच्चे को क्लियरली ब्लड प्रेशर उसका चेक करवाएं या खुद करें, ज़्यादातर पेरेंट्स खुद कर रहे होते हैं। और नॉर्मली हम कहते हैं महीने में 7 दिन लगातार किसी भी मशीन से आप चेक कर लो और नोट कर लो, ताकि अगली बार जब डॉक्टर को जाओ जाके बीपी की रिपोर्ट दिखाओ, बिकॉज HUS के अंदर ब्लड प्रेशर बढ़ जाता है। जैसे आपके डॉक्टर बताएंगे खून और पेशाब की जांचें करना। रिलैप्स जो है, जैसे मैंने बताया, रिलैप्सेस बीमारी में हो सकते हैं। मैक्सिमम रिस्क रिलैप्स का पहले 2 साल में होता है, और मेजॉरिटी रिलैप्सेस जो है इन्फेक्शन के बाद होते हैं। तो पेरेंट्स को एटलीस्ट हम लोग ये बताते हैं कि जब बच्चे को बुखार चल रहा है या खांसी जुकाम है और बच्चा ठीक नहीं लग रहा, तो पहले दिन तो नहीं, दूसरे या तीसरे दिन पे जाके उसके पेशाब की जांच करवा ले, या तो लैब में करवा ले या घर में जांच कर ले, तो पेशाब में ब्लड तो नहीं आ रहा। और ये आजकल यूरिस्टिक्स मल्टीस्टिक्स मिल जाती है, जिसमें आप ब्लड देख सकते हो पेशाब के अंदर। अगर पेशाब में ब्लड आ रहा है तो तुरंत हॉस्पिटल को संपर्क करिए। तो ये आखिरी स्लाइड है। आई थिंक इसमें मैं सिर्फ ये कहना चाहूंगा कि आपको जरूरी है एज पेशेंट्स कि ठीक डॉक्टर्स को चुनिए, लगातार उनको कॉन्स्टेंटली फॉलो अप करते रहें, जो डॉक्टर जो इस चीज में स्पेशलिस्ट हैं। हमेशा ध्यान रखें कि रिलैप्स का रिस्क है, और जैसे अगर लगे कि बच्चे को रिलैप्स हो रहा है सिम्टम के बेसिस पे या पेशाब जांच करने की बेसिस पे, तुरंत डॉक्टर को कंसल्ट करें। दिमाग में रखें कि HUS काफी सारे बच्चों में, डिस्पाइट वटेवर हम जो भी करें, बीमारी आगे जाके बढ़ सकती है। तो बीपी का ध्यान रखना है, पेशाब में प्रोटीन चेक करते रहना है, और दवाई वगैरह में उनमें गड़बड़ नहीं होनी चाहिए, दवाई ठीक तरह देनी है। और ये भी बहुत आवश्यक है कि आपस में इंटरेक्ट करें। जैसे कमल ने शुरू में कहा, ये जो सपोर्ट ग्रुप्स हैं, जैसे HUS फाउंडेशन है, या पेरेंट्स की जो ग्रुप है, ये बहुत इंपॉर्टेंट है आपको बताते रहने के लिए कि बीमारी के बारे में नई चीजें क्या आ रही हैं, नई दवाएं क्या आ रही हैं, क्या चीजें नई हैं। तो ये सपोर्ट ग्रुप्स बनाना बहुत बहुत असेंशियल है, और हम हमेशा चाहेंगे कि आपके ग्रुप्स बने ताकि आपको बीमारी के बारे में अवेयरनेस रहे। थैंक यू सो मच कमल, थैंक यू एवरीबडी फॉर दिस, फॉर योर अटेंशन प्लीज। I'll stop sharing. Thank you.
Thank you so much, sir, for that enlightening talk. I'm sure it was very useful to all the parents of pediatric patients. Moving on to the next talk for today. For the longest time, I think atypical HUS was always thought of as a pediatric disease, but recent data has shown that there are a large number of adults who get diagnosed with atypical HUS. And now, we've reached a stage where no longer is it considered a pediatric disease. I now invite Dr. Valentine Lobo, who is going to talk about aHUS in adults in India. Dr. Lobo is a senior nephrologist at KEM Hospital in Pune, with expertise in critical care nephrology, dialysis, and thrombotic microangiopathies. He is widely respected for his clinical acumen and patient-centered approach, and actively mentors young nephrologists. Dr. Lobo has a deep passion for atypical HUS And he was one of the first, organized one of the first ever conferences exclusively on aHUS a few years back in Pune called aHUS, An Evolving Mystery. With that brief introduction, I hand it over to you, Dr. Luba. Thank you so much.
Thank you, Kamal. Are my slides visible?
Yes, yes, doctor.
Yeah. Thank you so much, Kamal and aHUS Foundation. Also, Dr. Bagga, because he has laid the foundation and made my job very easy. The slides I am using, like his, maybe some of them may be confusing. Forget about it. Concentrate only on the few points that I'll be trying to make. So in 2024, in fact, a group of experts across the world decided that the terminology, the term atypical HUS is confusing और बताते नहीं कि ये बीमारी क्यों होते हैं. So they decided to update it, and they decided that thrombotic microangiopathy is a more appropriate term, and it may tell us something about the fact that there are different diseases. It's maybe appropriate that it's happened in 2025, which is exactly 100 years from the time when this disorder was first discovered and described by Moskowitz in 1925. So what happens? How do we diagnose this condition in adult patients? All patients will have what is called as acute kidney injury, which means severe kidney disease. Many of them will require dialysis at the time when they first come, and it has all happened very quickly. Along with anemia, so hemoglobin kam hota hai, platelet count kam hai. Most of the patients will have high blood pressure. Many will have low C3, but not all. And some of the patients come to us late, so ye platelet counts, anemia, these things will not be seen. And there is a particular situation, the commonest time in which we see aHUS in adults is usually during pregnancy or immediately after pregnancy in what is called as postpartum. And second most common is after certain types of snake bites. Now, I have not been able to establish as yet, though there are many studies from India and Sri Lanka, whether these people who get aHUS after a snake bite is because they have a genetic condition which makes them more likely to get it, or whether it is the snake bite only, because it doesn't happen in all snake bites and after kidney transplantation, of course. So how do we make the diagnosis? I think Dr. Bagga mentioned this already, that we look for anemia, we look for these schistocytes, we look for, we rule out infections like malaria, dengue, etc. We do an ultrasound and if necessary, an echocardiogram. So in 2024, what this group of experts from across the world told us that there are two things. If the patient doesn't have a complement related, or not, if this disease is not due to complement, but due to a clotting, a certain problem in the clotting, blood clotting, that is the clots are not being broken down by the body because of this particular enzyme, then it is called as TTP, thrombotic thrombocytopenic purpura. And if it is complement related, then they call it atypical HUS. Now, there are some situations, pregnancy, after transplant, after patients who have very high blood pressure, patients with cancers, etc., which are called as secondary aHUS. And there are two things that are required. Patient usually has a genetic disorder which makes him more likely to get this condition. And there is some condition, either infection, pregnancy, or drugs, etc., which trigger it. So they say genetic condition and a trigger. If the patient, if the trigger is very common otherwise and rarely causes aHUS, for instance, billions of women have had pregnancy, but only a very tiny number get aHUS, then there is a high chance that there is some genetic disorder underlying. Whereas, as what Dr. Bagga mentioned about Shiga toxin, you do not need to have a genetic disorder. So in fact, if it is Shiga toxin and aHUS, we will not look for a genetic disorder in such conditions. So the group has grouped into two: primary, where there is either hereditary or antibodies against some part of this complement system in the body, and secondary, which is caused in adults by drugs. Among these, oral contraceptives, quinine, which is no longer used anymore today, drugs which are used for patients with heart disease like clopidogrel, very high blood pressure, which is accounts for about 50%, autoimmune conditions like systemic lupus, some infections, some cancers, and organ transplant. Now, importantly, these secondary conditions and primary conditions, it may be very difficult to distinguish between these. In a recent trial of a new drug that was going on, there were 4 experts from across the world who had to decide whether the patient had primary or secondary and should be included in the trial. And very often, 2 experts, one would say yes, one would say no, it is secondary. And then they would require a third person to judge. So it's very difficult to distinguish many times between these two. And secondary does not again require genetic testing. So when I looked at in my unit, 121 patients treated in maybe the last 12 to 15 years, 40%, so that is more than 50 out of 120 patients, we got with aHUS after pregnancy. And another 16% came to us with after snake bite, namely with the vipers. And we were not doing genetic testing for a long time. When we started looking very early at aHUS, I was interested in the condition for more than 20 years. But genetic testing in India became widespread only in perhaps the last decade. So we found complement genetic disorders in about 9% of patients overall. So in secondary aHUS, there is always a cause which can be identified. High blood pressure, drugs, etc. And we do not need any specific treatment. We just have to treat the blood pressure, stop the drug. If pregnancy had occurred, then of course pregnancy again is controversial, and rarely plasma exchange is required. So pregnancy, and especially one of after pregnancy, is considered one of the major risk factors. It occurs in out of 25,000 pregnancies, 1 patient on average will get atypical HUS after a pregnancy. So sometime back we looked at this, 23 patients, one of my students published this study, and they found this, which we are still not clear how important it is. But what we do is, in all patients who have a pregnancy, a postpartum HUS, we do a genetic screening. And if they have younger sisters who have not yet been married or who have not yet had a pregnancy, we suggest to them that they should also be screened for susceptibility and very close follow-up, especially if a patient plans a second pregnancy. We do not have a way at present. So 88% of our patients whom we found with it had it in the first pregnancy, and we do not as yet know how to predict whether the patients will have it in the second pregnancy or not. We had one doctor whom we followed very closely in her second pregnancy, and it was absolutely smooth. Nothing happened. The patient went through smoothly. And another patient who just didn't come back to us after we had treated after the first pregnancy, came back after the second pregnancy with the same condition again. So there is no way of predicting as at now. In India, as Dr. Bagga already mentioned, eculizumab is not yet available, but will be in the near future. So we use plasma exchange in postpartum patients also. But in the Western world, all the Western series, they are using eculizumab. Every patient who has renal failure, kidney failure, low platelets, anemia after pregnancy does not necessarily have atypical HUS. And that is a good thing, because of these 4 conditions here, the others are much easier to treat and have a much better outcome than atypical HUS. So antiphospholipid syndrome is extremely rare. HELP syndrome, fortunately, is very easy. After delivery, the patient will be fine. So although she may have low platelets, anemia, etc., just have the child has to be delivered and the patient will be okay. And TTP responds very well to plasma. We do not need anything else. Though, again, there is a new drug called capelicizumab, which is now available. On to snake bite, which is the second commonest. Many studies from India, Sri Lanka, and a few from Australia. And all of these showed a picture like HUS. The first one was done by Date and Shastri in CMC Vellore about 40 years ago. They described that this happens with Russell viper bites. So Russell viper, saw-scaled viper, and hump-nosed viper in South India and in Sri Lanka commonly can cause this picture, and it is quite severe. We have seen 23 patients of such sort. and quite a severe disease. And in fact, there was 4 deaths out of these in the acute phase. And when we did biopsies, we found severe kidney damage as well. So this is a summary of what overall survival is good, 93 to 100%. It's better in Australia than in India and Sri Lanka. So we are not doing as well. And the main treatment against snake bite is a secondary type of thrombotic. So the main treatment remains the antivenom injections, and there is at present no recommendation for any specific treatment. Certainly not eculizumab when it becomes available, and even plasma exchange is being studied right now in Sri Lanka by the Sri Lanka Society of Nephrology. So their trial will tell us whether there is a real role for it in treatment or not. These are the recommendations about kidney biopsy. Every patient does not need a kidney biopsy. Most of the time, the diagnosis is made easily. But when it happens after kidney transplant, then we may not have anemia and low platelets. A kidney biopsy might be required. In patients who come late to the hospital, a kidney biopsy may again be required because the diagnosis may not be clear. If the clinical response is not good, patient response नहीं दे रहे जो treatment देते हैं, we would like to know whether it is worth continuing treatment, changing treatment, or just giving up at that point on the kidney. Such conditions, a kidney biopsy might be done in these patients. And these are how the kidney biopsies in some of them look. Forget about it. Genetic testing, again, not required at the initial time, not required for the diagnosis. It is required in some specific situations. And again, in 2024, this is the recommendation. Genetic testing has become fairly easy to do in India, but if it has to be done, then all these genetic tests are recommended. Sequencing has to be done. This other test has to be done. And importantly, most of the labs in India are not doing the risk haplotypes. Only one lab in Chennai is giving it. Most of the commercial labs are not reporting this. So we need to insist upon it when the test is being done. And because this particular genetic variant in C5 will decide whether the patient will respond or not to eculizumab. When we start using eculizumab, we will have to ask the labs to tell us about this as well. This is one family of patients whom I had treated. This patient over here was transplanted by me. I did not know at the time what the patient's disease was. She came to me as a chronic kidney, and her nephew, who had a transplant in another hospital, came to me when his kidney transplant was failing. We did a biopsy. We found aHUS, atypical HUS. We then went back and we found that in 3 generations, several members, up to 16 members of this family had either had kidney disease or had died of kidney disease. And that's when we went on to do genetic testing in them. So depending on which gene is involved, the outcome is bad or good. We need not remember it in this. This is one of our reports which we had done. And this is how the genetic testing looks. That if there are more copies, then the signal is higher. If there are less copies of a gene, the signal is lower. So let's skip this. Significance. Yeah. So this is genetic labs will report something, but it is important that the doctor who orders it interprets it for the patient. Otherwise, there can be a more confusion caused by a genetic testing, and there are practical guidelines which say that not every genetic report is associated with a disease. So it's important for the doctor who is treating the patient to interpret it, if necessary, to discuss with a medical genetist or other experts before giving the patient all complete information and to doing the counseling that is necessary. Eculizumab, which is going to be available, is going to come out as a first-line treatment. As was said earlier, in the Western countries, for about 15 years now, it has been available and is used, and it will be available perhaps soon in India. It improves the outcome tremendously. If you see here, 5-year survival of kidneys in patients who did not get about 40%, and with eculizumab 78%. Depending on which gene is involved, the results look better and better with eculizumab. And also, there are many other new drugs which have entered trials in many places in the world, including in India. I think All India Institute of Medical Sciences did a trial recently with crovalimab. We did a trial with iptacopan in KEM, which just now Novartis has stopped in India, though in other parts of the world it is continuing. So these are the countries in the world where iptacopan was tested. India was one of them, the United States, very small part of Europe, and Brazil and China and Japan, which were the main places. So these are all the trials across the world which are continuing with all the different drugs. Some of them are over here. These are some of the other eculizumabs, generics, which are being tried across the world, as well as many other drugs. I hope most of these will become available in the near future, either in trials or actually available to patients. I don't know what the costs will be. So that is probably the important thing, which was stressed by Dr. Bagga also at the end of his talk, that societies need to be formed. aHUS patients need to form support groups. They need to pressurize perhaps drug companies, governments, and other agencies to make drugs available and make drugs affordable for them. Thank you.
Thank you so much, Dr. Lobo, for that wonderful talk. I'm sure all the adult patients in this group and their family members learned a lot from that talk. I request all our attendees to please type in your questions in the Q&A, and once we finish the talks, we will take up all those questions one by one. Our next speaker is an aHUS patient himself. Shiv was diagnosed with aHUS a couple of years ago, and unfortunately he could not preserve his kidney. But I'll let him cover his journey. I'm sure all of us would love to know what other patients go through, because we rarely encounter fellow patients in our day-to-day life and when we go to meet our doctors and so on. So I'm handing it over to Shiv. I'll request him to please outline his journey for all of us.
Yes. Thank you so much, Kamal Shah, sir. And thank you, Dr. Valentine and Dr. Arvind, for your extraordinary presentation. It was indeed useful for me. And so, guys, I am a 32-year-old aHUS patient. Exactly 10 years back, I was having my first episode of aHUS. So I didn't know that it was aHUS, or neither the doctors who diagnosed me knew about it. It was fairly simple. The symptoms were like, your blood, you can found blood samples in your urine, which turns, pink or, mild red. And I had an episode of jaundice as well, with elevated urea creatinine values plus high blood pressure. So at that age, when I was 22, these were abnormal, blood pressure to have. And suddenly when the doctors figured out that there was a damage in my kidney, and I was immediately put to dialysis at that point of time. And they had a round of plasmapheresis for me as well, like 7 to 8 sessions of plasmapheresis. They were able to control down the hematuria, where the hemolysis and everything were stopped, but still they were not able to save my kidney. The kidney damage was already done, which was quite disappointing. But I was put on dialysis for the next 11 months, 10 years back. So in the 11 months, I had a very hard time of, doing dialysis. I was pretty, tall, fit, but what happens when people go for dialysis, you lose weight, a lot of fatigue, and, your work-life balance is a mess. So a lot of things happen, but luckily you get around it. You will definitely, come around it when you are in that position. You would get back in your feet, start working, etc. And with the support of your family members, etc. And the good thing happened was, after 11 months of dialysis, my kidney started to function again, but not with the full-fledged functioning. But the damage was done, but at a rate of like 35 to 40% functioning. For the next 10 years, it was functioning well. So from 2016 to 2024, my kidneys were functioning okay. And after 2024, again, I started having, the symptoms of, end-stage kidney disease, like, swelling of legs, fatigue, proteinuria, protein in the urea, the urine, etc. All those things were quite, visible. Then when we took the, ultrasound scan and other things, we saw that the kidney had failed again. So this time there was no escape for me. So currently I am right now doing dialysis and, learning a lot about my disease and other things. So one important thing I would like to touch upon here is about your genetic testing. So 10 years back, there was no proper genetic testing or, centers to literally identify what type of mutation, or is it because of a genetic mutation you have the disease or not. But last year I was able to find that out, and I have a CF5 mutation in my genetic testing. So we tested everybody in my family, my father, mother, and my sibling as well. So apart from my mother, everybody are tested for CF5 mutation, and unluckily, I'm the only one who had an episode of aHUS, right? And currently, I am actually I'm currently actually doing dialysis, waiting for a kidney transplant, and the transplant is also a little complicated. You might have a relapse after the transplant, because that is one of the major stress which can happen to your body. So that again, the complement factors, the breaking which Dr. Arvind told about, will not happen. So that is where I'm, right now. And the other important thing I want to touch upon is about how the government is helping this rare disease people. So there is a national rare disease policy. You can look it up in the internet if your rare disease is mentioned over that, and there are a lot of center of excellences available in each metro cities and other tier 2 cities. So go yourself, go there by yourself and get registered for the rare diseases you have, especially in our case like aHUS. And the government has a lot of subsidies and plans for covering your cost. I think it is covering up to 50 lakhs of your medical expenses through the government, through the center of excellences. So you can gather all the reports, your genetic testing reports, a letter from the doctor, and do visit these center of excellences and register yourself for this policy of national rare disease policy from the government. And that I have registered myself, and you guys can reach out to me in the chat or anything regarding the registration process as well. And yes, I am waiting for the medicines to be launched in India so that I can go ahead with my kidney transplantation. So there are a lot of complications with the transplantation. Again, my doctor has personally advised to, have a euclizumab therapy along with the transplant procedure being carried on. It's been a very tough journey, but I'm pretty sure that, if the family members and others, supporting, we can definitely come around it. And to see a lot of participants here in this webinar, I really feel that we are not alone in this, entire struggle. And thank you, Kamal sir, for, having this organization built. And I'm pretty sure this will be super duper helpful for everybody, who is seeking support, etc. in this rare disease. It's rare, but I think we are not common. I mean, it's getting more common now as we see a lot of participants and, in this foundation and the group. So that's pretty much, a high level understanding of my journey. And if you have any questions from a patient's perspective, please do put it in the Q&A session. I'll try my best to answer. So yeah. Thank you so much for this opportunity, guys. Yeah.
Thanks so much, Shiv, for that honest talk about your journey. It was really inspiring that despite all these challenges, you're still leading a fairly normal life, and you're taking such good care of yourself. Sir, Dr. Baga sir and Dr. Lobo sir, if we can just take a few questions that have come up in the chat bots.
Sure.
So there is a lady from Nepal who was a couple of years back thrombotic microangiopathy and then kidney failure, put on dialysis, several plasma therapies, and no progress. Kidney transplant was done. After 7 months, there was again 6 months of having transplant. Again, the kidney stopped working. Biopsy showed similar symptoms and recurrence of the disease. Now, she's back on dialysis, so she's would like some advice on how she can, what should be the further course of action. This is an adult patient, so I'll request Dr. Lobo to please take that up.
Yeah. I think the fact that the disease recurred means that there's a very high chance that she will have one of the pathogenic complement mutations. So the first step is to get a proper complete genetic analysis done. As I said, it needs 3 tests. It needs a gene sequencing, which today is very easily available and the cost is coming down. It will need what is called as a copy number variation. And at that time, the lab should be requested to give the information about haplotypes also, because should a second family member want to donate, then haplotype screening. And finally, the genetic test to know whether if she were to get eculizumab, would it be worthwhile for her to take it. So genetic testing would be probably the first step that will tell her what type of a disease, what is the further risk of if she were lucky enough to get a second transplant, what would be the risk of a recurrence, which I think is very high, and whether she would benefit from the treatments which are going to become available.
Thank you so much, Dr. Loba. I hope that answered your question, ma'am. A question regarding plasma exchange. How many plasma exchange sessions are required? How frequently are they given? The patient received 20 sessions. Is that correct? Is that suitable? Dr. Bagga, sir, if you could take that up.
Yeah, so if it's an anti-factor H disease, normally you require about 10 to 15 plasma exchanges because the autoantibodies levels decline quite rapidly after even a few exchanges. But we would still suggest, that you do a few plasma exchanges more. So at least 12 to 15, 12 to 20 is something that we normally advise. For non-anti-factor H autoantibodies, there you need to do plasma exchanges regularly for a while until you have access to eculizumab. Because only until then, then only you can probably stop plasma exchanges. But please remember that plasma exchanges is not an alternate to eculizumab. Whatever data that we have from all over the world, that clearly shows that plasma exchanges, other than for anti-factor H autoantibodies, अगर anti-factor H autoantibody है तो कोई फर्क नहीं पड़ता, वहाँ plasma exchange भी अच्छा है. But अगर autoantibody नहीं है, तो clearly eculizumab is better than plasma exchanges. So ये बात का ध्यान रखना है. Kamal, can I also answer the
Yes, please.
that I already answered? Gaurav had asked, what's the difference between thalassemia and atypical HUS? So Gaurav, these are two totally different diseases. Thalassemia is a hemolytic anemia wherein the destruction of RBCs is happening inside the bone marrow. तो RBCs बाहर ही नहीं आते हैं, वो वहीं पे there is ineffective erythropoiesis, so they die there itself. So, but it's only affecting the RBCs. HUS is a destruction, so the RBCs were fine, but they got destroyed by either complement-mediated pathway or other mechanisms when they were circulating. In addition, thalassemia में platelets normal होंगे, kidney failure बहुत uncommon होगा, HUS में सारी बातें होंगी. So thalassemia and HUS are two different diseases. Thalassemia only affects the RBCs, and वहाँ production की problem है, यहाँ destruction की main issue है. यहाँ there things are being destroyed because of complement dysregulation.
Thank you so much, sir. Dr. Lobo, a question on pregnancy. When would a pregnant lady exactly know if her baby is affected by this disease?
Yeah, so in the first place, we wouldn't routinely test a baby unless the mother or there is a strong family history that some family member, maybe more than one family member, or the mother herself is affected. When can it be known? If it's a genetic HUS, the genetic test can be done immediately after birth if the parents so desire. But there is something called penetrance, which means how many proportion of people who have a risk factor, a genetic risk factor, will get the disease. It's about 50%. So there are lucky people who have, and I think it was presented somewhere also that I think the Shiv said it, that everybody in his family has the CFI mutation, but only he has disease. So even a genetic testing tells you about risk, but doesn't say 100% you will get the disease or not. And finally, 50% of people all over the world whose genetic testing comes negative have had HUS. So it's still evolving. In some years ago, there were 5 genes. Today, there are about 22 genes which are tested. In the future, who knows? There may be many more.
Thank you so much, Dr. Lobo. There's a question: in an outpatient or clinical setting, how can we differentiate atypical HUS, typical HUS, and TTP based on presenting symptoms?
So do you want me to answer?
Yes, sir, please.
Can you just go back to the question? So in a outpatient, how do you distinguish between typical HUS, atypical HUS, and TTP? Now, as Dr. Lobo said, these terminologies are generally being given up, except for TTP is still there. But so if you have a history of dysentery followed by HUS, suppose you've got blood in the stools, and a few days later you get features of HUS, that's most likely Shaker toxin associated. Suppose you've got pneumonia, or suppose you've got some other disorder, and then you get HUS, that's that disorder causing or predisposing to HUS. TTP is a disorder that mainly affects, fortunately, it affects chiefly adults. Thrombocytopenia, platelets are going to be much more lower. they'll usually be in the range of 20,000, 25,000. The kidney failure is not too bad. Our adult colleagues often use a score called the plasmic score to be able to distinguish TTP from HUS. But the plasmic score really relies on the presence or absence of kidney failure and the severity of thrombocytopenia. So more severe thrombocytopenia is more likely to be TTP. The diagnosis of atypical HUS is really a diagnosis of exclusion. So if you excluded Shigella, excluded infections like malaria, dengue, and so on, snake bite, pregnancy, secondary causes of HUS, then you would think about atypical HUS. Only in a very small proportion of atypical HUS would you get a low C3. So having a low C3 is not necessary for atypical HUS. Less than 30% patients would have a low C3. So the diagnosis is still clinical, but I can say today with enough confidence, that most of my colleagues across the country are able to make the diagnosis reasonably well, based on just clinical criteria. Dr. Lobo can add to this. Dr. Lobo, sir.
I agree, sir. Nothing to add. I agree fully.
So I'd special shout out to three people from outside India, from international, from the US and Canada, who've joined us for this webinar. Linda Burke, who's one of the world's leading patient advocates in atypical HUS. We have Jeff Schmidt, again, one of the leading lights of the aHUS patient community, and Margaret Eigenram from Canada, who's again from aHUS Canada. Thank you all for joining us. Linda has a question for you, Dr. Bagga and Dr. Lobo. Could you please provide insights, updates on the status of clinical trials for aHUS patients in India?
As far as I know, 2 trials, as I mentioned, have been done. At the moment, both of them are over, to the best of my knowledge. Dr. Bagga would be able to add. Crovalimab trial, which was done in, I think, 4 centers in India, and the iptacopan trial, which was done in 9 centers, including us. Iptacopan trial, probably because India's population is so large, they reached their target number very quickly in India. They are continuing it in some of the other countries, but the recruitment rate seems to have fallen off tremendously. As long as India and China were on the trial, there was a rapid recruitment, and both those countries have reached the targets. So I hope Novartis gets their target number quickly. We'll know whether the trial was successful or not, and whether that drug is going to become available. Those are the 2 trials I'm aware of. Dr. Bagga.
No, I think that's fine. These are the only trials that we are aware of. But one does require more trials, particularly in the domain, Kamal, of anti-factor H autoantibodies. And we've been saying that, because you have plasma exchange there, and you have an alternative therapy, which is there as well. So clearly, you do require a trial for the autoimmune disease. So there's definitely a scope for more, and we are sure, as new drugs come in, we do look forward to more trials happening at academic centers in our country.
Thank you so much.
Yeah, about 7 years ago, we started with Covaxin. There was a UK pharmaceutical company which started the Covaxin trial with us. We screened 2 patients, and then the trial was just closed down by the company. And Covaxin has disappeared from the literature also since then.
Okay, that's interesting. Dr. Bagga, if you could take this question, how to decide between what is better, plasma exchange or plasma infusions? So
I would always, if at the onset, it should always be plasma exchanges, because plasma exchanges. So even if you don't have access to eculizumab, plasma exchanges allows you to give a much larger volume. Something like 60 mils per kg can be exchanged, whereas during the infusion, you would normally give 10 to 20 mils per kg. So clearly, you can give larger volumes. So clearly, I would prefer doing plasma exchanges initially. Maybe on the follow-up, suppose you do get a patient who has got factor H variant or a factor I variant, who doesn't have active disease now. On follow-up, one could manage with plasma infusions, maybe once in 2 weeks or once in 10 days. But please keep in mind that this is not the best form of therapy. The best form of therapy would still be a complement inhibitor. So definitely plasma exchanges. If not, then you can try infusions. But again, I would prefer that for follow-up rather than the acute stage.
Thank you so much, sir. One more question. Thank you so much for the insightful sessions. As we work towards a public awareness campaign for aHUS across age groups, could you please shed some light on which key stakeholders, including those on the healthcare provider side, should be engaged to ensure accurate information sharing and early diagnosis? Also, from your experience, could you suggest some focus areas we should keep on our radar, like symptom recognition, referral systems, or treatment access, to make aHUS awareness campaigns more impactful and truly rooted in community needs? I'll leave it to both of you if you could add some light on that.
Dr. Lobo can go first. Sir.
Okay, so one of the things, and I think Dr. Rajiv Sinha in Kolkata, for instance, is making a very strong case that every region of the country needs to have good reference labs. At present, only All India Institute of Medical Sciences has the reference method of doing anti-factor antibodies, which is which is a major cause of the disease in India. In adults, it's variable. But certainly more than what the Western studies tell us, 5 to 10%. Our own postpartum cases, we had 20%. And recently, Narayan Prasad's group from SGPGI, they have reported 56%, which is practically the same as the AIMS paper in children. So certainly good method, good reference labs to test for anti-factor H antibodies, which provide accessibility. Even we are using a modified method, which we validated with the help of the Newcastle lab, and seems to do fairly okay for us. So good testing, as I mentioned earlier, genetic testing. So interpretation of genetic, we take the help of our medical genetist in KEM. Fortunately, when we get a genetic report, we also do some of the functional tests to help us if we can get the sample when we get a genetic test. So diagnosis is going to be important. Eculizumab, even when it becomes available, or any of the other drugs, I'm sure they are going to be very expensive. So making the diagnosis correctly before putting a patient onto these medicines, there's a controversy still, especially after transplant. The drug will probably have to be continued for life. So making the diagnosis, making the decision, this is going to require reference centers with the expertise available. It's a good thing that the government has identified centers of excellence. KEM Mumbai is, I know, one of them. So I've registered 2 of my patients who are waiting for transplants on the KEM Mumbai list, so that if they should get transplants, they will have access to the drug when it becomes available. That's what I could think of in the context of this rather large question.
So my feeling, Kamal, would be, that we obviously need to reach out to our colleagues across specialties, particularly hematologists. Even at the All India Institute, and I'm sure Valentine also agrees, that people don't even think about the condition. Patients are managed as anemia or ITP, and it's only, a few months later when the kidneys fail that they seek attention. So I think one is obviously reaching out to co-specialties, making physicians aware, just like, in children, this was done for obstructive jaundice, that if the eyes are yellow beyond 2 weeks of age, reach out to a doctor. So I think there has to be some kind of a thing that I think we are underdiagnosing the disorder, number one. I totally agree with Valentine regarding, more labs doing it. And the good thing is that people are gradually, even in our country now, KEM has been doing it, AIMS has been doing it as well, as have other centers across the country also. Gradually, they are doing it locally. But it has to be, Dr. Lobo, effort, that as the effort was made by you, the effort was made by the All India Institute. So it has to be, nobody can mandate this effort, And there has to be a certain degree of commitment by the nephrology community, I would imagine. Uske bina nahi ho sakta. That's the very core minimum. The good thing is, Dr. Lobo and Kamal and others who are listening in, the Spanish group has developed a point of care test. So it's just like, you do a pregnancy test. So you put a drop of blood in that slide, and if you get a band, the autoantibodies are there. We have been working on it. My colleague at AIMS, Dr. Aditi Sinha, has been working on it currently with the group in Spain. So it's possible, that over the next few, and currently also there is a ICMR funded project happening with THSTI and AIMS on a point of care test. So the answer will lie on a point of care test finally. Just like you've got, so when you get a patient in the casualty, you do a point of care test. If the antibodies are there, you go ahead. I think we have been fortunate in India in certain ways that we have had autoantibodies in about 50% of our children. Otherwise, we would have been in a mess. You can imagine having the same spectrum, you would have had so much more ESRD than what we currently have. The third thing is that, again, I think it's important as a community, and that's the concern that I share with my other colleagues at AIMS, is that once eculizumab becomes available, it's going to be expensive. So physicians are going to cut corners. They're going to give lower doses. They're going to increase the duration of therapy. So again, we will not be, the same thing happened with other monoclonals. So again, I think there will have to be enough pressure from within our community. The physicians per se will have to be, reactive enough to act on these to ensure, that we don't change the standard of care. Our doses are appropriate, the relation between doses is not messed around with. So these were some points I had in mind here.
Yeah, thank you so much, Dr. Loban, Dr. Baga. Very quickly, I'd like to cover some of the, Shiv already talked about it, but a little more detail I'd like to give about government support for aHUS patients that exists right now. Very quickly, I'll just summarize in a couple of minutes. Unfortunately, we've run out of time, but hopefully we'll be able to go through this quickly. I hope you can see my screen.
Yes.
Yes.
Okay. So there is, like Shiv mentioned, a national policy for rare diseases run by the Ministry of Health and Family Welfare. It offers financial help and access to care for rare disease patients. 63 rare diseases are covered and aHUS is included. Now, usually aHUS patients are not used to good news, but here is one piece of good news that aHUS is included in the national policy for rare diseases. This policy groups the rare diseases into three. One which can be cured with a one-time treatment. There's another second group that is lifelong treatment but low costs. And then the third, which is treatment exists but very high costs. As I think all of us are aware that aHUS comes in the third group where treatment exists but it's very high costs. But what support is offered by the government today? It's up to 50 lakh rupees per eligible patient for treatment. And there is a little bit of flexibility that the government has talked about, especially in the group 3 cases like aHUS, where based on the patient situation on a case-by-case basis, they can make certain extensions. The important thing to note is that treatment has to happen only at the designated centers of excellence, and I'll talk about what that is in a minute. And another good thing from the government side is there is no GST or customs duty on the rare disease drugs that are imported for the treatment under this policy. Now, these are the centers of excellence that have been identified. There are 12 such centers of excellence, and we should all be aware of which is the center of excellence that is closest to us. And here is the first 6. And here is the second 6. This is available on the MOHFW's website. These links are all available on the website of the Atypical HUS India Foundation, which is www.ahus.in. The site is www.ahus.in. So I would strongly urge you to go to that website and then check out these centers of excellence names so that you can identify something that is closest to you. Now, why do you need to know which is closest to you? Because it is really important for all of us as patients of aHUS to register with these COEs, right? So that we can come under the National Policy of Rare Diseases program. So we should talk to our doctor immediately about registering with the COE, as this program is only under the COEs and the registration has to be done by a doctor. It's not as if a patient can themselves register, it has to be done by a doctor. There is a basic medical evaluation that will be done. There's some documentation that you need to provide, some history, tests, and an identification. There's an application form, and then you basically wait for approval. So this is broadly about the government support. We should be aware that treatments for the disease are not currently officially available. Some treatments will become available over time. The cost of these therapies is still unknown, but hopefully things are looking better as of now compared to what they were looking a couple of years back. So hopefully things should get better very soon. Yeah, so that's all I had, but there are a couple of more questions that have come. What is the cause of atypical HUS? Pretty wide-ranging question.
So it's essentially, atypical HUS is chiefly complement mediated, and that's the new terminology. As we said, in about half the children, we have antibodies to factor H. In about 20%, there would be genetic mutations in one of the complement genes. As Dr. Lobo also emphasized, in about 30%, you will find no cause. It's possible that there is a cause that we don't understand now, but our overall feeling is that majority of atypical HUS, the way we currently define, is complement mediated because of dysregulation or overactivation of the complement pathway.
Sure. I think we'll take the last question, which is, why do you think aHUS remains so unheard of among the general public, even among healthcare populations? What are your suggestions via which we can reach out to people or make people more aware about it? Dr. Lobo, if you could take that.
Yeah, one of the reasons why perhaps it isn't noticed is it's a rare disease. So the incidence in children is, I think, 2.5 to 3 per million population, and in adults it's half of that, 1 to 1 point. So it's a rare disease. Second is that there are so many other diseases which are much more common where the clinical picture is similar. So we said about dengue, malaria, such type of infections. There is very often both exist together, an infection and a predisposition to HUS. Snake bite, as I mentioned, where this snake bite group, it will be up to us in India and Sri Lanka to prove whether this is part and parcel of complement mediated, or it will fall eventually into one of the secondary group. And the third is that, as Dr. Bagga also mentioned earlier, it's up to us as nephrologists and those of us who have a special interest in the disease. So I had an interest for a very long time, and for a very long time, I didn't have much of an understanding. And then gradually starting to do things, I was not very careful about documenting my own stuff to begin with. Then I began to do it. Colleagues helped me. Then I came to know what about the work that AIIMS was doing. I read that. Then we reached out to people across the country, and our knowledge has grown. So it's now up to us to start spreading the awareness. Dr. Bagga mentioned it already. We need to reach out to our hematology colleagues, for instance. I started the ADMTS 13 testing in KEM, and then my hematologist colleague began to use it, and he was happy that I had started, but he hadn't thought of starting it himself. And it was not all that difficult. It was easier than anti-factor H antibody to do, actually. So the part of the responsibility will be on all of us who are interested in the disease for whatever reason to spread the awareness.
Yeah, thank you so much, Dr. Lobo. That's very interesting. Shiv, you have a question?
Oh, yes. This is for the doctors here. There is a small, doubt for me. Like, when can a patient withdraw from this therapy? Is there are there any examples of such patients who have, gone out of the therapy? If yes, what kind of mutations are, which can help us to, remove from the therapy after some point of time?
Should I go, sir?
Yes, Bulis.
Yeah. So there are, in fact, because it's an expensive treatment, governments all over the world, even in Europe, are hesitant about once the patient is on continuing it for life. So there have been studies which have attempted to withdraw it after 2 years of therapy, and some of this is published. There are reports which say that if the patient has a definite, or the group which falls into what are called as definite pathogenic, meaning disease-causing mutations, then the rate of relapse is 1 in 10. Unfortunately, 1 in 10, 9.5 patient years. If it is what we call variant of unknown significance, again, there seems to be very high relapse rates. But where there was no mutation detected, the relapse rate is pretty low. If somebody has had a transplant with a recurrence of the disease after a transplant, then I think he will have to continue for life as per whatever our current understanding is.
Thank you so much, Dr. Lobo. I think with that, we will have to wind up because we've gone way above time. Those whose questions were not, we could not answer them during the webinar, please send them to ahusindia@gmail.com, and I promise you we will request our two speakers to get back on those questions. Please send those questions to ahusindia@gmail.com. Also, doctors, some people have asked for how to get in touch with you and get an appointment and how they can come and meet you. What we will do is we'll publish this information on the website after we'll get the details of your appointment system from you separately, and so viewers, we will get you the details of how you can take appointment with Dr. Bagga and Dr. Lobo and let you know as soon as possible. So I think we've come to the close of this webinar. I'd first of all like to thank Dr. Bagga sir and Dr. Lobo sir for their valuable time on a working day, taking out time to talk to us patients and clarify so many aspects of the disease in this first ever webinar for aHUS patients in India. Thank you so much, sirs, for taking out the time. Shiv, thank you so much for sharing your journey. Very, very inspiring. Thank you so much, Shiv, for sharing your journey with us. I'd like to thank all the attendees who've joined us today and encouraged us to do more such webinars in the future. Please visit our website, and there are a couple of things that I would request you to do. One is to register with us and give us some basic details so that we can build a database of patients, which will be very useful for us to do more such activities and to talk to companies who are thinking of being active in India, so that they also are aware of the patient base that exists, and we can do more such webinars and so on with your support. I'd also like to request you to sign up for our newsletter so that periodically we'll send you information about the disease and what is happening in this space in India. And I'd like to thank AstraZeneca for supporting us in this webinar. Without their support, this webinar would not have been possible. Thank you so much. I also like to thank Kidney Warriors Foundation and Vasundhara Raghavan for their unflinching support in all our patient-centric initiatives. So thank you so much. Good evening. Goodbye.
Goodbye.
Thank you.
Thank you so much. Thank you.